are very good, very interesting, different topics. And what I've done is I've just gone through the titles as well, and then we talk and discuss what can be done, what can we change, and how can things happen. So, and Professor Roland also has been very nice, I think, because he said that descriptive studies would do. What is a descriptive study? So I'll just made a presentation. So if I go to our previous presentation, which we have done last time, let me open it up. So in this presentation, I hope you can see it now, right? You can see my slides.
Waiting for that. Did the light get off? Did the light get off? We couldn't see because the light just got off.
Okay.
Now it came back because the projector got off because of the light.
Okay.
Now we'll be back.
Yeah. Okay. Right. So can you see my presentations now? Wait. Now, can you see my presentation now?
Yes.
Okay. So when we see, this is the last presentation that I made, and we talk about how to write a synopsis. This is the first step that would be moving forward, and I asked you to write something about the. We got the broad guidelines, the headings, total words, language, objectives, and timelines. Then we talk about the title pages, right? And then we thought that we'd be working on the title plate at the end. So move on to the introduction part. This is what you have already done, right? So it is nice to have 4 different topics. Everyone has contributed, and I believe that they are good topics. They are, you have followed the para 1 and the para 2. So what we need to do is to establish what we can do with the para 4. Sabra, if you find something something goes wrong, let me know. Okay.
I'm just trying to switch off the audio from this. So because the echoing system.
Okay, because you have to, the Shukri has to log out then. If Shukri is not around, that's fine. Otherwise, Shukri has to log out. Similarly, I think Abdu has logged in, so he also has to log out. That is the reason why we are having. So I'm removing, I think Abdu.
Now keep Shukri because the slides, the desktop, you're sharing this came only in Shukri's, did not come in Atman's. So we are using both computers. What to off? Can we off your?
So okay. So if okay, I don't know. Let's see what you can do.
He's not hearing you, quite close one.
Okay, no, just on it. Okay, so no problem. We just have an echoing system. I hope that no problem.
No, I okay. I'll mute everyone. So just a moment, because I have to stop. I need to mute all. Yes. And then unmute the MacBook Pro. Can you hear me now?
Sir, we can hear you. You were just, the screen is not displaying in Afnan's MacBook.
Ah, I see. So because he would have put some restrictions there. So so how can you now see my screen then? Can you see my screen now?
Please, no. Yes. Yeah, now it's fine.
Okay, good.
Absolutely.
Okay, good. So what I was,
Yeah.
sorry?
And we will from Shukri, sorry. Shukri will leave.
Okay, okay. So we will work out how can this can be changed. But regarding the last presentation, we thought about the introduction, which you have very nicely submitted some suggestions, and I think that we will go with them because they are good. But we will be changing something in it. So we have to improve the introduction parts a bit, and then that would be based on what we know, what I would be discussing today, right? So I'll move on to today's presentation,
Right, sir.
because okay, so this is the, so I need to change this one. I stopped shooting. Okay, so I'll turn this off, and then I turn this on, because this is, so I must congratulate uh, Shukri. You didn't tell me you are an international author. Do you know, Shukri, that you have a paper published uh, yesterday, actually, and in January or February 2020. So I picked up Shukri Dahir, right? That's you. So I came to know that you are an author in international. So I think you should be the teacher, and we should learn from you. How did you do that? Okay.
I was good
Yes.
collectors. I don't
But still, you're mashallah a good author. I mean, number 5 in an international journal, published in World Journal of Surgery. This is good enough. You're ready to be promoted as a senior registrar already.
She is, even in her skills and capabilities. Yeah.
I thought she is. I mean, this is very nice. Okay, so what we need to do is, please again, please confirm that these are, I have written your name on it. Post-operative surgical site infection in Hargeisa group of hospitals, by Sadiq, right? A good study, and you say that we need to know the incidence and the distribution of surgical site infection, right? So this is a good idea. But then again, Shukri submitted the incidence of goiter in adult female patient in Hargeisa. Again, a good topic. And we're talking about incidence and goiter. So the head and neck surgery would come in this paper. The next is Adnan's. Adnan says extrahepatic biliary diseases, and the topic is prevalence of extrahepatic diseases. Prevalence, you topic of the prevalence, right? Focus on what we are thinking about the in the title, and then we need the surgically treated acute abdomen. So the subject, I believe, is patients with acute abdomen. Here, the patients with extrahepatic biliary disease. So this forms the P, right? The P of the PICO that we discussed yesterday in the last lecture. PICO and the population. So we're talking about these subjects. And I need to know to really explain something. What is prevalence? Prevalence is the proportion of a particular population found to be affected by a medical conditions, number of patients with the condition divided by total number of population that is studied, and is expressed as a fraction or a percentage or a number of cases per 10,000 or 100,000 people, right? How do you explain this? You explain this in a form of cake, right? A fruit cake. So the prevalence is the number of these red fruits in this fruit cakes, right? So if we take a point prevalence, or a period prevalence, the period prevalence is the number of cases, the red cases, the total number of red cases that are present in 1 year, in 6 months, in 3 months. So that is a prevalence. And point prevalence is when you cut the cake at one point. So that is a point prevalence, that you cut it at one point, and there is the chances that the number of cases that are already there would be different from the January to June or December. This is prevalence. This is the concept of prevalence. Now, if you want to do something with the prevalence in your hospital, I mean, hospital is not the place for prevalence. Hospital would not give you the prevalence, because every patient that is coming to your hospital does not represent the whole population of Hargeisa. Yes, you can think that the population that you are talking about represents the whole of the population, but what if you operate at 1,000 patients and 700 of them are doing cholecystectomies or gallbladder disease? Does that mean that your population, which would be maybe 5 million, so that means out of 5 million, 3.5 million people are suffering from hepatobiliary disease, a huge proportion. So that is not the prevalence. We're not going to study the prevalence because this is an epidemiological study. We're talking about a different perspective. Doing surgery in research is different and is much easier as compared to the epidemiological kind of a things. Second important point that you have mentioned again and again is incidence. Now, what is an incidence? Incidence is a measure of probability of occurring a given medical condition in a population within a specified period of time. This means there is a number of new cases during some time period. For example, the incidence of coronavirus last year was 0. And the incidence of coronavirus in the world in January and February would be in hundreds of thousands. So that is the incidence. Again, you cannot identify incidence in a study specifically when you're trying to do a clinical research. Why? I say, if I go back to this topic, I need to know the incidence of goiter in adult female. Incidence of goiter in adult females. Okay, so incidence, the number of new cases. You will only have new cases. So that means you will have 100% incidence. So that won't do. So these are epidemiological terminologies, and is not something to do with me and you surgeons. Surgeons are good with other things. So I'll let you know how are we going to change this. So I think I've been able to convey the correct message. Incidence and prevalence are something with the epidemiologists, and that is to be done on the whole population of the country and not on one hospital. So how to choose study design? That is an important part. Which is the most common study type designed in surgery? I need your comments. What do you think?
It used to be descriptive, and then
Descriptive.
it's changing now into randomized trials. They are more favorable, and after that meta-analysis and probably.
Okay, very good point. Very good point. So does Shagri thinks differently, or Khalid thinks differently? What is the most commonest type of surgery of surgery? I'm saying of research is being done in surgery that has been published.
Is it case control studies?
Case control studies, okay.
Probably retrospective studies.
Retrospective studies, okay. So where is Adnan?
Experimental studies. Experimental studies.
Adnan, and we have isolation.
I said experimental studies.
Okay, okay. So I also believe, Khalid, you have to unmute your account again, please. Thank you. So I also believe that randomized controlled trial is the most common study being done in surgery. But then I'll give you a few examples. This is one of the examples. The outcome after emergency laparotomy as a secondary level hospital in rural Zambia is a good study type which we can adopt for one of our studies, maybe all of our studies. So we talk about outcomes after head and neck surgery, outcome after laparotomy, acute abdomen, outcome after hernia, maybe at a tertiary care hospital in Hargeisa, right? So this is a good design which we can adopt for all of our studies. It would be easy to do. When I go to the index of the annals of Royal College of Surgeons of England, not a very high-fi. I mean, is not an impact factor of 14, 15. So to just have an idea, what is being published there in Journals of Surgery. So the first topic is diagnostic accuracy of the fecal immunochemical test for colorectal cancers in risk stratified symptomatic patients. I mean, there is a comparison group, but this is not a randomized controlled trial, right? This is not a randomized controlled trial. Next is a surgical margins of borderline and malignant phylloides tumor. Again, this is not a randomized controlled trial. The third is the effect of preoperative stroma training on patients undergoing colorectal surgery in an enhanced recovery program. Tumor length as an independent prognostic factor in resectable esophageal carcinoma. Management of uncomplicated primary inguinal hernia, systematic reviews, and then an introduction to an enhanced recovery protocol into a laparoscopic living donor nephrectomy program. In pediatric surgery, the need for pediatric emergency laparotomy audit. In breast surgery, this is a level 3 dissection in locally advanced breast cancer following neoadjuvant chemotherapy, a retrospective study. Arthroscopy, I'm leaving the upper two. The last one is a case control study of 30 days mortality in periprosthetic hip fracture and fractures. I mean, if you look at this, and I search a number of journals that have published, so randomized control trial is not the most commonly performed research. That makes our life easier. I mean, we are not going for a randomized controlled trial as a thesis, right? So we'll taking something easier, and that would be acceptable. As Professor Olan already said, that we can take a simple descriptive study and can be used as a requirement for our degrees. So quickly working on the study designs, because this is important. What you have sent to me is a very prelim idea and is a good idea. So I would like you to continue with those ideas, but I need you to identify which type of study now you are going to do on this. So there are two types of quantitative studies. One is original research. The other is a review of public research, published research, right? If I'm talking about the original research, I need to identify an intervention. Did I do something? So in all the topics that you have sent to me, you have not identified any intervention, right? So we're talking about prevalence of head and neck problems, prevalence of extrahepatic biliary disease, maybe which I change that word, the incidence to outcome. So outcome of patients with goiter, outcome of patients with extra hepatic hepatobiliary diseases or stone diseases, then outcome of patients with acute abdomen, outcome of patients with surgical site infection. So in all these, we are not actually specified any intervention. We are not talking about that effect of, for example, of antibiotic on surgical site infection. So we have not changed anything. We have just worked as a bystander and just look at what is happening. So everything has been done. We're not talking about retrospective or prospective studies. We're talking about only that there was an original research. It's not been published anywhere. So I want to see what happens to all patients coming to my hospital from January 2020 to December 2020 with hernia. I mean, okay, so this is an original research, but there is no intervention. So move on to the observational study bound. But if we do something, even if I say the effect of taking 3 spoonfuls of honey 2 hours before the surgery, I want to see the impact of this on something, on wound infection, on outcome, on any stupid thing. I mean, I can say the chances of becoming hypoglycemic, but I can't try. I mean, but there is an intervention involved. So if we involve this intervention in our topic, then we move on to the experimental study arm. In the experimental study arm, now we need to know whether we have a control or not. Again, a very important point. What is a control? A control in which it is a group of people very identical to the people that I'm trying to work on. So if we're working on female with goiters, so I need to have another group of female with goiters on which I am not applying that specific intervention, right? So for example, I'm using cautery, monopolar cautery and a bipolar cautery. So I have two arms. One says monopolar cautery, the other arm is a bipolar cautery. But what is the standard? So I need to have another arm of control in which I'm not changing practice. So that is the control arm. So am I involving a control arm? We need to say, now this is a controlled trial. So if I'm not using this controlled trial, I'm doing an uncontrolled trial. So it's a number, it's a group of people that I'm not changing the practice, right? I'm not changing the practice. I'm saying again. So one patient, I'm not changing a practice. The other, I'm changing a practice. The third, I'm changing another, a treatment A, a treatment B. So in the controlled trial arm, it's confusing, right? But it's the same. We'll discuss it again and again, and we'll learn how it works. In the controlled trial arm, if we have a random allocation, now this is known as a randomized controlled trial. So if we have a random allocation, we have a randomized controlled trial. But if we do not using the randomization and we are including all consecutive patients in, it is a non-randomized controlled trial, but we have a control arm. So it's a bit difficult to do a randomized controlled trial. What we want to do would be, we would like to do, I'm going back, that we need to find a small, simple intervention so that this is an experimental study and not merely an observational study. And then we'll move I won't think we'd be able to include a controlled arm. So we can simply do an uncontrolled trial. Or if we add a controlled trial, it would be a non-RCT. Well, we can do a randomized controlled trial, but we need to, there were lots of things that we need to add to this. Coming back to the observational study arm. So if I start with the clinical research again, this is an original research, nothing published before this, but I'm not entering anything. We're not changing the practice. This is the observational studies. What you have all suggested are this group of studies, observational studies. So not changing things. But in the observational study arm, so we need to define, is there an association of something? So if we want to if there is an association of temperature, of weather, season, with presentation of goiter. So we need to analyze using these forms: a cohort study, a case control study, a cross-sectional study, or ecological studies. I will not go into the details, right? If you want me, so I can have another lecture on only on these 4 or 5 types of lectures. But if you think that, we're not using this, we are going for an experimental study. So is a good option not to discuss these observational studies. If yes, then we can again discuss these things in detail. So if an observational study, if there is a clinical research, an original research, but we have not done anything, it was the patient came to our ward, he remained in ICU, there was a certain diagnosis, and then he went home, or we operated on a patient and found something very interesting. We did not change the practice, and then we want to publish this. So it's an observational study. There is no association. So we need to include this as in a descriptive study. or descriptive epidemiological study, and it includes case reports and case series. Moving to the other arm, which I believe that we can start in parallel to what we are doing at the moment, is review of published literature. There is no new study being done, so we do not need to have ethical approvals. We do not need to have um, really an idea, an intervention. We simply do a literature systematically reviewed. If not reviewed, this is known as a narrative review. Otherwise, we do a systematic review. And if you are analyzing a number of systematic reviews, we name it that meta-analysis, right? So these are the group of, these are the different groups of studies that we would be discussing, right? So let me come down. I hope I have made things a bit clear, right? Sabra.
Yeah, absolutely.
Okay.
Yes,
So
sir.
if there is a confusion, stop me, because with the online lectures, the only problem is you never know what is, if anything is I'm unable to clarify, just let me know. Okay. Okay. So I am quoting two examples of systematic reviews. A systematic review of the safety and efficacy of non-operative management in patients with high-grade liver injury, and a systematic review of outcomes reported in small bowel obstruction research. So in this, there is no new research that is being done. Is actually the actual word, the research. You need to research the literature and you write a review. That is a systematic, in a systematic fashion. That is a systematic review. That is very simple to be done. And but you need to work very hard. You need to read all the articles and 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 move forward with this. There is a consort trial. This is available on equatornetwork.org, right? So you can, I'll show you the screenshot from that as well. Whenever you'll want to start something, you can easily go into that. And this is the consort trial checklist for randomized trials. So it includes everything that we have already discussed. But this is how you're going to write it, because this is how we're going to submit it for approval to with the what you can say is as a registry, clinicaltrials.gov or other registry. But this is how we're going to report it in your articles. Okay, so if I look at this paper, this is from BJS Open, latest, published on 19th of March, 5 days ago. It says the regional pancreaticoduodenectomy versus standard pancreatic duodenectomy with portal vein resection for pancreatic ductal adenocarcinoma with portal vein invasions, right? If you identify, this has two procedures. So we have a procedure A comparing with procedure B. Then we have an intervention, which is portal vein resections. We have a patient population, which say pancreatic ductal adenocarcinoma with portal vein invasion. So this is the population. These are the pancreaticoduodenectomy is the intervention. The comparison the groups are the regional or the standard pancreatic duodenectomy, and the outcome is what would happen to it later on. So if you look at when you look at the methods, you find that this retrospective study included consecutive patients who underwent pancreaticoduodenectomy with portal vein resections. What I want to emphasize is that this study is retrospective. So this means that there was no consort for this. It would not have been written in a form of a randomized controlled trial, but it does contain everything that a research question has. It has a population, it has an intervention, it has a comparison group, and it would be having outcome. The outcome is the extent of lymphadenectomy was similar between the two procedures. Okay? So we can change this retrospective into a prospective study style, and start working on this. So an extended cholecystectomy, maybe a cholecystectomy using one suture material, or one clips versus another clips, or some small intervention, little intervention, and that can be very easily help us to design a research. If I take another one, we have the effect of structured use of preoperative portal vein embolization on outcome of liver resection of perihilar cholangiocarcinoma. If you look at this again, this is not a randomized controlled trial. This is again published in 17th of March 2020. It's a single-center retrospective study in which consecutive patients undergoing liver resection under suspicion of primary hepatic carcinoma 2000 to 2015 were compared with patients treated 2016-19 after implementation of more liberal approach. Again, there is a true comparison group, but this is a retrospective study, not a difficult study to be done because everything is there. Anastomotic leakage after elective colorectal surgery, a prospective multi-center observational study. I'm quoting all these things to really explain. See, anastomotic leakage after elective colorectal surgery is a prospective study, a multi-center study, but is only an observational study. So if you take down that chart that we have just discussed, and that this is an experimental study, but we have not done anything. Despite the fact that it was an observational study, it was an interventional. Some intervention was done, but it was not us. It's been done by someone else, and me as an author is not changing anything. So I'm just reporting what has been done, how it has been done. So this is one form which we can use in our study design. This is also research. I mean, okay. So obesity is associated with worse outcome among abdominal trauma patients undergoing laparotomy, a propensity match nationwide cohort study. This is an epidemiological study. We are not going to do these kinds of studies, but we can do these kinds of studies. These are cohort study in which we make up a score, maybe identifying a difficulty index for doing a thyroid surgery, a difficulty index of doing an open cholecystectomy, difficulty index of doing a complex hernia surgery, and then we mark the number 1, 2, 3, 4. So this is also an option that we can adopt. Moving from here, what would be our next challenge would be the sample size calculation. Sample size calculation, as you have noticed, when in many of the studies, we would not be requiring sample size collection. Actually, if we're just moving on to preparing a descriptive study, we do not need, I repeat, a sample size estimation. So sample size estimation would only be done if we have an intervention, because then we would be having comparison groups. Then we would be requiring some test for clinical significance. Otherwise, it's a simple descriptive studies. And we need to start in January 2020, finishing December 2023. This is the number of patients we have. And then we'll apply the tests of significance only for the outcomes, males and females, elderly and young. And again, this is not what we would be planning at the start of the study. This is a simple descriptive study. But we need to understand, I would be discussing the sample size estimation in more detail in my next lecture. So just to give you an idea, what are the 4 things that we need to talk? I'll sharing you with the documents as well. We need to have a hypothesis, a null hypothesis, and an alternative hypothesis. And need not to get really worried about the difficult terminology that statisticians use. I'll try to make them very simple. I hope the cake thing and the prevalence thing makes things easier to understand for surgeons. These are something to made us frightened from the statistician. Hypothesis, null hypothesis, alternate hypothesis, and an alpha type 1 error, a beta type 2 error, and power of study. So I would be discussing in my next lecture about in details how can this be done. So we can leave this slide for the time being. Not going to discuss this, but I would just give you an example. This is the Falcon trial, and it says how they calculated the sample size. Now remember, this is an RCT. This is a randomized controlled trial. It says that there will be two trial strata. One would be clean contaminated cases. The other would be contaminated or dirty surgeries. So we have included whatever the intervention is. We are including two different types of operations, which have different characteristics. We cannot compare clean contaminated and contaminated because in research that has already been done, the outcomes would be given in different number. The SSI rates would be given in different number. One, the infection rate is 10%, the other is a 40%. So we cannot match them, grouping them together. We have two strata, right? So what we have done with different interventions, effects are specified for each stratum based upon the perceived differences in clinical impact. Sample size was based on, so if you look at this slide, hypothesis, type 1 or the alpha error or a p-value, beta or the power of study, so beta error and the power of study. So now see, you have a 90% power, a 5% two-sided significance level, that the alpha is a 95%, and 15% lots of follow-up or a death prior to reaching the primary endpoint. So they have taken these three factors again to calculate the sample size, and it turns out to be, I thought I have missed it, but this is something 2780 patients in the clean contaminated group and 2700 patients in the dirty group. So this is how a sample is calculated. A bit tricky, but it's very simple. I now want to ask you to change the topic that you have sent.
Sir, can you please say it again? The slide,
This one?
the last one, yes.
Okay. So there are four things, four components: hypothesis, the alpha error, beta or the type 2 error, and the power of study, right? When we are going to write the sample size calculation, we need to take into account all these four things. If I want to make a study with a big sample size, I will increase the power. I'll keep it the alpha error usually to the 95% or the 5% significance level, and we have a bigger sample. And the effect size, I didn't mention the effect size. So the effect size is small, the sample size has to be big, which means if I want to tell you that the taste of two ice creams differs significantly, so I cannot decide on two samples. I need to repeat the test again and again, maybe 1,000 times, and then say that company A makes an ice cream which tastes significantly different as compared to the type B, though the ingredients are the same. So if the difference is small, drug A has an efficacy of 80%. Drug B has an efficacy of 82%. In order to have a significant result, which means I need to show that drug B is better than drug A, or a treatment B is better than treatment A. So I need maybe 1,000 operations to identify that among the 1,000 operations, I found that the infection rate was 700 in this and 600 in the other. But if I have a treatment option in which one treatment option efficacy is 40%, and the other treatment option, the efficacy of 90%, so the effect size of 50% makes it very easy. Just 30 or 35 patients in each group, and I can show that yes, there is a difference. And then I suggest to the rest of the world that you can move on to design a trial with bigger number to really identify whether there is a difference or not, right? Am I clear now?
Yes, sir.
Yes.
So if there is still a confusion, I know
Yes.
it's difficult to understand. But this is how what we be trying to learn by putting them into formulas, right? So the smaller the effect size, the larger is the sample size, and the greater the effect size, the smaller is the sample size. Similarly, the smaller is the power of study, the smaller is the sample, and larger is the power of study, larger is the sample. So I need to be really sure that 90% of the patient fall in the right group. I will be discussing these things in detail in my next lecture. If you have a question, just send me the questions and I'll try to find an answers. I do not promise I could answer them. So this is what an objective was sent to me, is surgically treated acute abdomen in Hargeisa group of hospitals, right? Who sent this?
No.
Adnan, right? Okay. So I made certain changes. So I want to change this into the to add these. So to determine the outcome. So all objectives have to be smart, have to be objective. So to determine the outcome of surgically treated acute abdomen patients in Hargeisa group of hospitals. But again, these are maybe a very large population, every patient, all patients. So I need to explain what is a Hargeisa group of hospitals. So we need to explain there is a tertiary care hospital or a secondary level or a primary level of hospital. So whenever a reader reads it who has never been to Somaliland, by reading the title understands that this is a big hospital, or this is a smaller hospital, or a district hospital, or this is a basic health unit. Then I need to again add something, add information about what patients. Are you taking adults only? Or are you taking children also? So we need to specify your objective. So I would add adult males, adult females, simple adults, or children, or a pediatric group. Or if I want to be very, very broad, so I would write every patient. So if I add every patient, so the spectrum of the diseases that would be coming in, the results that would be coming in would be very varied. The diseases in children are different, and adults are different, and then really it would be difficult for me to control the sample size, the results, the comparisons, the genders, lots of things. So I want you to be focused on one group of patients, right? Then I add to determine what do you want to see, the outcome, right? The outcome. So I would like to add a few more things. I need to determine the short or the long-term outcomes. Are you focusing primarily on the short-term outcomes, wound infections, 30 days mortality, 30 days wound infection, or you want to see recurrence of hernia after 6 months, recurrence of a disease after a year, long-term hypocalcemia in patients with after thyroidectomy. So so that would decide how long the study would go. If I say that I want to see the long-term effect of recurrent laryngeal nerve injury or a change of voice after thyroid surgery, and I would like to see that what would happen if a patient after thyroidectomy after 5 years. So that is a long-term outcome, a difficult study to do, but still is a good study. But as a researcher, you need to be clear that what you want to do. Okay, so, and then I need to add some novelty in it. So it's been, this thing would be very simple. Determine the short and long-term outcomes of surgically treated adult patients with acute abdomen in tertiary care hospital in Hargeisa, right? So I add something. So I further squeeze down that sample to traumatic and a non-traumatic, either of them. So this would help me. And this in trauma, if I say, okay, Sabra, what is the most common cause of trauma in your setting? What is the most common cause of trauma in adults in your setting?
Stab wound.
Stab wound.
Yes.
What
Stab wound.
uh-huh. So if you once shared a patient in which you had a crush injury by a camel.
Yes. That was very unique.
You see, so
Animal bites, it's common. Animal
okay.
bites in general. Donkey bites, we got hyena bites sometimes
Mhm.
from periphery. Camel bites, yeah, it happened like a couple
See,
of times.
see, so you have such a nice article coming out from Hagiza to determine the long-term outcome of surgery or a short-term outcome of surgically treated adult males after being bitten by hyenas in a tertiary care hospital, right? So you need to think. And if you have maybe 30 patients coming in a year, it is an absolute beauty. In a beautiful article would be coming up. Nobody in the world would have thought about this. You won't be finding lots of hyenas causing injuries, camels causing injuries, which are being published because the novelty is coming from these areas. So I want you to, all of you, to think and improve your objectives. I thought I would be able to change all the four topics that you have sent me, but I thought again that I would be doing it. But it's a good idea that each one of you add something, add these topics to ideas to your topics as well. In the end, for today, we're talking about this website. This is Equator Network. So the equatornetwork.org is a very good website. In this, if you see on the right side, I hope you can see my cursor moving. Sabra, do you see my cursor
Yeah, we
moving?
can.
Okay. So
Yes.
if you're trying for, now you have a list of study designs that we have just discussed. If I'm going to write a case report, I'd click on the care guidelines and just fill in the forms. I mean, what is missing, what is there, and how is it should be written. What with the randomized control trial, I have a consort checklist, and so would be filling it out. For observational studies, remember now these are regional researchers, but there is no intervention. I have not done anything. So it can be a cohort study, it can be a case control study, it can be a cohort study, or it can be an ecological study. But it use a strobe checklist. For systematic reviews, you have Prisma, study protocols, you have Spirit and Prisma P. For diagnostic and prognostic studies, you have a STARD. For case report, you have a CARE, clinical practice, you have AGRI. For qualitative research, you have two more, and animal preclinical. This is not for us. Even I do not understand how they are going to do this, right? Okay, so here I'm going to stop. Let me quickly click on this slide. So this is the most important thing that we have done today. We need to decide now which type of study are we going to do. I believe that the topic you have sent to me are good, but all of them need some polishing to do. And by the next lecture, maybe you need to identify. I'll send you this presentation, post this presentation to you as well. So maybe just I took this picture from Google. So nothing copyright, but you need to identify which arm are you going to take. Each one of them we can fit it because Professor Ron has said that we can do anything, but he requires certain good things. So I would recommend that every surgeon must do something with the surgery thing so that helps him or her improve the skills and would benefit to her after completion of her training as well. So this is the most important things. We are going to pick which of these topic or arms are we going to take, and how are we going to polish these four topics that we have discussed, right? Where they go, these. So this for Shukri, Adnan, and Afnan. All of them are good, very nice ideas. I need you to polish these, develop them into a full good PICO objective or a research question, and identify how can you or how do you want to. I do not want you to just complete and send it me. Keep sending it to me. Maybe WhatsApp on the group. So this is an idea everyone can share, discuss, and by the next lecture I would discuss sample size calculation, one. And number two, I want each one of you to identify which type of study you want to do. That would be very helpful, and so that we would be able to submit our research proposals by end of maybe middle of April or end of April. What do you think?
I think end of April, sir, it will be good. So we have 1 year and few months to work in it.
Wow,
Because
good.
we have September is 2021 is their last day of training. Yeah.
Okay. So that means we can take something observational as well with some intervention arm, or we can take a simple intervention included in this. Maybe a role of honey in wound infections. Maybe use of some specific suture that you use that you usually do not use. Maybe wound infections after subfascial closures. Maybe taking a small bite of the rectus sheath. Anything would work. Anything would work really. If not, then simple observation study, simple descriptive studies would do. Simple descriptive studies can be difficult to do at times because lots of variables needs to be really included,